All right, everybody. I think we're going to go ahead and get started here with this month's presentation. Today, we are going to be hearing from Dr. Hayek, who is going to be doing a presentation on opioid use disorder and a few other things, followed by a brief Q&A session. Other than that's all I have. So without further ado, here's Dr. Hayek.
Great, thank you for the introduction, Evan. Hello, everyone. Thank you for being here. My name is Dr. Saif Hayek. I am a research scholar and research assistant at Insight Research Institute and at the Center of Cognition and Neuroethics at the University of Michigan in Flint. So today we will be talking about opioid use disorder, medication-assisted treatment, and ongoing clinical trials at Insight. So the main objective today of this PowerPoint is to spread awareness and about opioid use and the importance and how significant it is as a major problem occurring not only over the world, not only in the United States, but all over the world. So today we will be talking about defining opioids. We will talk about how opioids work. We will talk about where are opioid receptors located and clinical manifestations, commonly used opioids. We will touch on the definition of opioid use disorder, problems with opioid use, the opioid epidemic by numbers, treatment options. Then we will move on to talk about how Insight Research Institute is involved in clinical research. What is a clinical research study? And then about a digital therapy and who can join the study that is related to opioid use disorder. And what can the study participants expect? And then we will end this off with contact information to join the study and then a Q&A. So what are opioids? Opioids are a class of drugs that are naturally found in the opium poppy plants. These can cause, or naturally founded opioids can cause a lot of effects in our body and in our brain by inhibiting the neural circuits. And one of the things that it can cause is pain relief. Usually opioids medically are prescribed for moderate to severe pain. However, unfortunately, they can also cause people to be happy and relaxed. And I say unfortunately is because this can cause some sort of dependence and addiction. So how do opioids work? Opioids, there are indigenous opioids and exogenous opioids. Opioids that are already, believe it or not, produced from our own bodies, and they're known as endorphins. So those endorphins work on enhancing the release of dopamine, which plays a very important role in causing this state of euphoria, which is, you can say, feeling high. And that effect, as I mentioned earlier, can cause dependence and addiction. Another way is that dopamine, if worked on the pain system in the brain, can inhibit or block pain from occurring. And that's the advantage of opioid in a clinical setting. So it is highly related. The clinical symptoms are highly related to where the opioid receptors are found in our bodies. So for example, if we have opioid receptors in the central nervous system and they get activated, we can get clinical features such as respiratory depression, analgesia, which is pain relief, euphoria, and pinpoint pupils. The stimulation of peripheral receptors, especially found in the smooth muscles of the lung cells, the bronchi, and the intestines, can lead to constipation induced by opioid and cough suppression. Now, these are commonly used opioids, and the ones that are listed here are prescribed opioids. We have a variety of prescribed opioids going from hydrocodone, known as Vicodin, to oxycodone, Percocet, oxymorphone, morphine, codeine, and fentanyl. And I want to focus a little bit on fentanyl here because fentanyl is a synthetic opioid, and it is many times more powerful than other opioids. Now, it is approved to be prescribed, but under certain settings, which is if you want to treat severe pain, typically in advanced cancer pain. There has been a rise, and we'll talk more about this, in the illegally made and distributed fentanyl in the United States, and it has caused many, many issues. I haven't listed here one of the opioids as well, which is heroin. Heroin is, because it's not a prescribed, it's actually an illegal opioid. And unfortunately as well, the heroin use has been increased in the United States among men and women, most age groups, and all income levels. So when you say opioid use disorder, how do we diagnose opioid use disorder? How is someone an opioid user? So here we have the DSM-5 criteria for substance use. Now, each one of these numbers is 1 point. Now, if someone scores 2 to 3 points, that's mild. 4 to 5 is moderate. More than 6 is severe. So if you get failure to fulfill responsibilities, use in physically hazardous situations, if you get cravings, if the using of opioids causes social and interpersonal problems, if you use larger amounts or longer than intended, if you cannot cut down on opioids, and if you spend a lot of time getting, using, and recovering from opioids, if you give up or give less importance to other significant parts of your life, that's 1 point. Ongoing use despite problems, having tolerance, which is basically not getting to the same effect the first time you use the opioids as before. So you would need a higher dose of the opioid, and getting withdrawal symptoms when stopping the opioid. Now, what is the problem with opioid use? It can lead to physical dependence within a short time, as little as 4 to 8 weeks. Abruptly stopping opioids in chronic users can lead to severe symptoms, and that would include generalized pain, chills, diarrhea, restlessness and anxiety, vomiting, insomnia. So all of these severe symptoms usually can happen when someone cuts off the opioid if they were chronically using it. Another problem is that it has been very accessible in our day and age to get these opioids. And unfortunately, this has contributed a lot to an opioid overdose crisis. This is a chart from the United States Department of Health and Human Services. This was published in 2020, and it states the 2019 data of how many people have used or died from heroin or other substances. So you can see here that 1.6 million during that year, people had an opioid use disorder, and around 745,000 used heroin specifically. Now, around 70,630 died from drug overdose during that year. So from these figures, we can assume that it's a high number of fatalities that are related to opioid and heroin specifically use. This is another interesting graph from the CDC that states the deaths per 100,000 population over the years from 1999 to 2019. And we can clearly see that over here, the synthetic opioids, such as fentanyl, which I talked about earlier, has a very severe, or you can say steep peak, especially when you're comparing it with 2018. So that's around like 15% and that's from the data, around 18% increase, 15% increase from 2018 to 2019, and around 73% of all opioid-involved deaths in 2019 was related to fentanyl. Now, there were reports that said that there are a number of drug submissions that was obtained by law enforcement that tested positive for fentanyl, but not fentanyl prescribing rates. So that report indicates that this increase in synthetic fentanyl is actually could be more likely to be illicitly manufactured rather than pharmaceutical. We can also note here there is a 6% and 7% drop from 2018 to 2019, respectively, of heroin and commonly prescribed opioids. So that's something to look at as a comparison. But still, heroin compared to 2011 is around 11 times higher in usage in 2019. So this is an interesting graph that gives us a little bit of an idea about the significance of the problem here of how much amount of people are using opioids. So what are the treatment options? There are 3 FDA-approved medications for treating opioid addictions. So we have methadone, which has, or known as an opioid agonist, and has a full positive effect on opioid receptors. There is the buprenorphine, known as a partial agonist. And then you have a naltrexone, which is known as an opioid antagonist and blocks the effect of the opioid receptors. Also, there is a medication known as naloxone, which is a potentially saving medication used to quickly reverse an opioid overdose. It can reverse and block the effect of other opioids and return to normal breathing to someone whose breathing has been slowed down or stopped because of an opioid overdose. Now, it's important to note that methadone is actually available only in specially regulated clinics, while buprenorphine is provided by specialty trained and qualified physicians, nurse practitioners, and PAs who receive the waiver from the DEA. Naltrexone is available from office-based providers in pills or monthly injections. And we will talk more about how we approach these patients with opioid use disorders in details. So when it comes to, if a patient comes in with an opioid use disorder, won't a psychosocial therapy alone be enough, or is it preferred to do a medication-assisted treatment? So the idea here is that studies suggest that medication-assisted treatment is recommended as a first-line therapy rather than psychosocial treatment alone. But does this mean that we cannot do psychosocial therapy alone? We can. There are certain situations. For example, if the patient has a history of prior sustained response, or if the person has a milder disorder and is highly motivated for treatment, if he has a good premorbid functioning and a strong psychosocial support, or if the patient has a strong preference for psychosocial treatment alone despite education of medication-assisted treatment. These are the cases where, okay, we can start them on psychosocial therapy alone. There has been an interesting paper that I've read recently. It was a systematic review that included 24 clinical trials and around 8,000 patients. And it studied how substance use disorder in general, if involving patients in making decision-making, whether that would improve drug use outcome at a 1-year follow-up. And they found positive results coming from this. So involving patients in the management plan when it comes to opioid use disorder does bring up positive results. Now, when do we use long-acting injectable naltrexones, and when do you use buprenorphine or methadone? So we use naltrexone in mild opioid use disorders usually, and usually the patient should have had stopped any sort of opioids before starting naltrexone. Now, the reason why we start with naltrexone is because of three things. First, if the patient illicitly uses another opioid while on naltrexone, the patient will not get any effect or euphoria, which is that feeling of high. And naltrexone does not cause physiological dependence or withdrawal symptoms when stopped. So that's unlike methadone and buprenorphine. And the last point is that you can, if let's say you start a patient on oral naltrexone and then you follow it up with a long-acting injectable of naltrexone, you can, if the patient is not tolerating it, switch to buprenorphine and methadone without having this washout period like you have to do in buprenorphine and methadone. So that is why naltrexone is used in mild opioid use disorder. Now, what about in moderate and severe? So there has been available data that suggests that methadone is actually, on average, slightly more efficacious than buprenorphine. In most clinical circumstances, however, buprenorphine is safer than methadone. And that's why buprenorphine has been used as a first-line medication for patients who come in with moderate to severe opioid use disorder. So what is Suboxone? Suboxone is basically a combination of buprenorphine and naloxone, and it should only be given when the patient is in a state of mild to moderate withdrawal. And that is actually one slight disadvantage of buprenorphine, is that it can precipitate or worsen opioid withdrawal symptoms if not administered carefully. So there is a clinical opioid withdrawal scale that the patient has to score around 10 to 12 more or higher in order for them to, let's say, get Suboxone administered, or there are certain symptoms that they should get before taking in Suboxone. When buprenorphine is administered to a patient with withdrawal, he or she can get a net gain of opioid agonism and relief from the withdrawal symptoms. So I've put here the next two slides. The reason why I put this screenshot is because I wanted to point out the importance of how different could it be from if a patient is using short-acting opioids from a long-term opioids, and how long they should wait before they are get administered with buprenorphine. So, and that is for them not to get into a phase of crash or getting worse. So in short-acting opioids like heroin, oxycodone, morphine, etc., they shouldn't use the buprenorphine for 8 to 18 hours and they should get some withdrawal before they can actually take the tablets. And here is for long-acting opioids, methadone, extended release oxycodone, morphine, and they should stop the methadone around 36 to 96 hours before and get some withdrawal symptoms before actually taking in Suboxone. And for morphine and oxycodone, around 24 to 36 hours. And this is known as the induction phase. So it's important for patients, and it's usually a 3-day, but it can differ from one patient to another, for them to get on a steady state of non like cravings and like normal state. Now, what are the clinical trials on? There has been a lot of clinical trials that show that medication-assisted treatment helps a lot in reducing substance use compared to placebo in patients with opioid use disorder. Now, there are here at Insight several clinical studies that are taking place that focuses on the medication-assisted treatment and opioid use disorder. But first, what is a clinical research study? Clinical research study is a medical research involving people. It helps scientists and doctors to explore a medical strategy, drug, or even a device, whether it's safe or effective. Taking part of a study, of course, is a patient's choice. And there are certain ethics and rules that the doctors must follow when undergoing a clinical research study. Now, there is two types. There's the observational and clinical trials. Clinical trials involves intervention. Observational does not. So here we are working at, as I mentioned earlier, clinical trials that involve people with opioid use disorder. Now, the current study that we're working on is actually, it actually involves the medication Suboxone, which I talked about earlier, and a digital therapy. And if you participate in the study, you will be randomized into either the interventional group or the control group. Now, the interventional group, you would receive the Suboxone with the digital therapy. And for the control group, you would only receive the Suboxone only. So what is this digital therapy? It's basically a web-based software program, and it uses motivational interview-based techniques, just like seeing a therapist or a healthcare provider. But instead, it'll be like on your tablet, on your phone, on your computer, and it's just an easier access. It's used in combination with medication and counseling for patients already receiving or requiring medication-assisted treatment as part of the recovery plan. So who can join the study? Now, you may qualify for the study if you meet the following criteria. If you are between 18 to 65 years of age, you're able and willing to use and enter information about yourself in a web-based program. But I should note that your personal information is going to be kept private and only you have access for that information. Now, positive urine drug test has to be there during the first study, and an overall good health. Other requirements would apply. So what can a study participant expect? Now, the study is 6 months, and it includes basically the patient will get the opportunity to be screened. So they will receive health assessments, and we would make sure they qualify for the study. They will receive an opioid use disorder medication if eligible for that. And they will get access for the digital therapy. Let's say they do not fall into the group that of only the Suboxone, no digital therapy. They can get the access after the study is complete, as digital therapy is been still in progress and we're still working on. And there will be weekly study visits, so that will help the patients stay on their toes and motivate them and try not to help them not to relapse. So there will be like weekly visits, follow up during that time. So I would like to acknowledge our research team, Dr. Abbott, who is a board-certified doctor in pain medicine and addiction medicine, and he's the principal investigator in our study. Dr. Garaiva, who is our research director. Dr. Paladuku, the clinical research coordinator. Dr. Aramadan and Dr. Gzawi, who are my colleagues, the research scholars here at Insight. If you are interested in this study or any other studies here at Insight, this is our contact information. Thank you.
All right, thank you, Dr. Hayek, for that presentation. I think it's great that people are finally shedding light on the opioid epidemic that we've been facing, especially the use of naloxone and Narcan, things like that. However, that does bring us to our Q&A session at the end here. And to kick things off, I did have a question myself. Is there a particular set of demographics or a population that is most susceptible to opioid use disorder?
Well, there has been, specifically in demographics of lower social populations of lower socioeconomic classes, and yeah, so that class is highly susceptible for opioid use.
Okay, I see. And at this time, I will allow anybody to unmute themselves, ask a question for Dr. Hayek, if you have one, or you can type it in the chat and we can read it as well.
Dr. Hayek, I have a question. How effective are methadone clinics in helping treat people who suffer from opioid use disorder?
That's a great question. Actually, Dr. Abbott, I hope he is here with us. He might actually help us and benefit us with that answer.
Oh, hello.
Yes, hello, Dr. Abbott.
Oh, hi. Yeah. Just first of all, excellent presentation, Dr. Saif. Thanks for all the information. Regarding, I just wanted to clarify. I'm not board certified in pain. It's in preventive medicine. So just for that small clarification. And then recently, just now in addiction medicine. Regarding the question on methadone, I think the question was how effective it is. It is very effective, but the participants do not like it because they have to usually go every day to get it, and then eventually they can get supply or for the weekend, I don't know the exact details because some methadone clinics, they have like a little bit of freedom in giving for a little bit longer for patients, but not like for with Suboxone, we're able to give for patients for even a month. So patients would prefer the Suboxone program, and also patients can overdose and die in methadone. And on Suboxone, you could also do theoretically, but it's extremely rare, and so that's why it's much safer to be in the Suboxone program or buprenorphine. Suboxone is just one of the brands. Yeah. Thanks.
Thank you, Dr. Abbott.
Just to kind of add a little bit more on that, basically, if a patient's able to be like have structure and have good urines, then the buprenorphine is preferred. But if a patient is having substances repeatedly in the urine and particularly like opioids, then they may need that more closer observation, and then we either refer them to methadone clinic where it's a more structured environment, or to rehab and detox, so then they could be in an environment where they can be away from the drugs. Thanks.
Thanks for answering my question.
All right, any other questions out there?
Thank you so much, Dr. Hayek. That was an excellent presentation. And by the way, I'm Leela Paladugu. I'm the lead clinical research coordinator for the clinical studies here being conducted at Insight. I would like to take this opportunity to welcome, everybody is welcome to advertise these clinical studies, and please help us out in recruiting the patients. If you feel anybody is eligible, please directly contact us at research@iimm.com or 810-275-1964. Thank you.
Thank you, Dr. Paladugu. Okay.
All right, it looks like that is it for questions. Again, I'd like to thank Dr. Hayek for that presentation. Looks like you're getting lots of praise and positive feedback in the chat here. But that does conclude this month's presentation. I hope everybody has a great rest of their day, and thank you again, Doctor.
Thank you so much, Evan. Take care.
Bye, everybody.
Thank you, guys.